Thank you for being here on Saturday morning. I know it's not always the easiest time to be up after a long conference, so we appreciate everybody being here. My name is Carina Siracusa, and I am a physical therapist at Ohio Health. Today my colleague and I are going to be talking about provision of wheelchairs for the client with MS. We have a little bit of a special situation and a special setup with our MS clinic, and so that's what we're going to be talking to you guys about today, as well as some case studies and some different challenges that we've run into with this client population. To tell you a little bit about myself, I've been a physical therapist since 2005, and I am the coordinator for our seating clinic. My actual daytime job, the rest of the time, is I'm actually a pelvic floor physical therapist, and most people are like, how do those two marry? I was a pediatric therapist before I ever became a pelvic floor therapist. So, and my role in the MS clinic is I am the pelvic floor therapist for the MS clinic. I see a lot of those clients, but then I also see them in wheelchair clinic as well, and I do all the administrative stuff as well as see clients for seating clinic.
And I'm Lauren Esposito. I'm a physical therapist. My role is primarily in the MS clinic, so this is a very special topic to me, and it's really why I got into wheelchairs. I was in the clinic all the time, and I just saw patients who came in with a very bad situation, to say the least, because they never went to a seating clinic to really get them what they needed. So then I started transitioning to the wheelchair clinic as well on my off days from the MS clinic. I also treat outpatient neuro clients as well, primarily MS.
And we just want to also, because our third colleague is not here, Andrea Stump, she had a baby, so she could not come to ISS, but there is a third person in our seating clinic as well that helps us to run it, so I just wanted to give a shout out to her. She's very sad that she can't be here.
So, as you see, we really have nothing to disclose. No financial interest in any products. So I want to start by talking about what is MS, because I think if you don't understand the diagnosis, you can't seat someone appropriately. It's a very challenging diagnosis to work with, and it's often misunderstood, especially if you haven't really read the newest literature on MS and what's going on. So MS is a progressive neurological disorder that affects your brain and your spinal cord. It causes a wide range of mobility issues. So you could have a sensory ataxia, you could have just chronic neuropathic pain, you could have a balance deficit, you could have hemiparesis, you could have a monoplegia, you could have quadriplegia, any of those things. We often see tons of spasticity in the setting of MS. It really depends on where you have your MS attack or where the lesions are in your brain or your spinal cord as to what symptoms you're gonna have. So you can't see the diagnosis of MS and say, oh, this is what they're gonna look like. Every single person will look 100% different from the next. The other biggest factor that I think plays into seating the client with MS is fatigue. So they have this chronic malaise, so a lot of it is cognitive fatigue, but the other type of fatigue that is so important for all of us is motor fatigue. And that's really gonna play into how you as a clinician evaluate the client. And then you're gonna be variable in your progression of the disease. So we're gonna go over the 3 different types of MS as well. So the first type and the most common type is relapsing remitting. So how this is defined is they have a clear, distinct episode of time where they have new neurologic symptoms followed by partial or complete recovery. And as you see on this scale, typically at the very beginning, you're having complete recovery. So maybe you were hospitalized for hemiparesis, you get infused with steroids, and then within the next month, you really kind of return to your baseline. But over time, as these relapses add up, you're having progression in your disease, progression of your disability, you're having more white spots on your MRI, more disease activity. Now, the other thing that you have to be aware of, and oftentimes clients will talk about, I had a flare, I had a flare, I had a flare. Are they really having new disease activity on their MRI, or is it a pseudo-relapse? So any instance of infection, so a UTI, a cold, the flu, they get overheated, any of these instances, which all play a role in how you're gonna seat them and what you're gonna provide them, may worsen their old symptoms, but it doesn't necessarily mean that they had new activity on their MRI, which is important to know. Secondary progressive MS. So there's some debate if you really get into the nitty-gritty with a neuroimmunologist about whether this is really a thing, but currently it's a thing. They'll argue with you. So typically it follows the initial course of relapsing remitting, and then you start saying, I'm getting worse, but I'm not having distinct attacks. They might not see new activity on their MRI, and they've just kind of started progressing over time. So that's what most people are calling secondary progressive. And then you've got primary progressive. So you've really, when you meet with the neurologist, they're gonna ask you kind of, what is your, tell me your story, basically. And they're looking for those distinct episodes of time where you were hospitalized for some sort of symptom, complete numbness on one side of your body, complete weakness on one side of your body. But with primary progressive, they don't really have that. It's just been a steady decline, and it's not fast. I think one of the biggest misconceptions of MS is that you're just gonna get worse. You're just gonna get worse, you're just gonna get worse. That's not the case. The average lifespan of someone who has MS is almost identical to your able-bodied person without a disability. Maybe 4 to 6 years difference. But I mean, I treat people who are 94 years old. So don't look at it and say, you're just gonna get worse. They have a whole lot of life to live. Average age of diagnosis is between 30 and 40. So they've got a lot of life to live. So then when we're talking about mobility issues, so we have to think about, what type of MS they have, what's their length of need. So we often have this term when we're in the MS clinic and I'm with the neurologist and we're looking at MRIs and we say, they haven't had any new disease activity, but they're catching up to their MRI. So you might see a 30-year-old who's walking around without a device, and really nothing has happened in terms of their imaging, but they had a really, really, really aggressive disease onset initially until they got onto a drug, and now they're catching up. So they might not have distinct episodes of relapse, but now they're starting to look like their scan. So in those instances, you might need to be more aggressive in their seating because it's not following a discrete path, and one of our case studies is gonna look at that today. Do they need it really only in a period of a relapse? And so this is a lot of times where I come in when I'm in the MS clinic, I see a client who's relapsing and they can't transfer by themselves. And I call Carina, I said, this is an urgent appointment. We need to get something, and sometimes our vendors will give us a loaner product because I don't want them coming home from the hospital, seeing a therapist who doesn't do seating, and they're coming home with a standard manual that they will never be able to propel. And then 5 years later, then we can send them to the seating clinic and get them an appropriate chair. Motor fatigue. So this is gonna be the biggest thing like I talked about. They may look great walking for 25 feet, and you have them walk for 50 feet, and their leg is completely dragging across the floor, they can't pick it up, they sit down and recover for 2 minutes, and they're good to go. Or I can propel across, carpet for maybe 20 feet down your hallway for you to look at me, but I'm done, and I can't do anything in the rest of the day. I'm wonderful in the morning, but around 3 o'clock, I really can't do anything. I need to take a nap. So you need to understand that motor fatigue aspect of MS to give someone an appropriate chair. And then the aggressive and highly active client. You do have to play a little bit of a crystal ball game. We've heard a lot of people who were speaking, over this conference that work in the VA. In our outpatient clinic, when we're dealing with a lot of commercial insurance, we don't have the benefit of, I'm gonna get you a power chair and I'm gonna get you a manual chair. Unfortunately, we're playing the insurance game at some point in time. So you have to know, do they have aggressive MS? Do they have highly active MS? How many drugs have they been on to try and stop this disease? So now we're gonna talk a little bit briefly about, the clinic and what we do. So it's a multidisciplinary clinic. So your first clinic appointment, you're gonna come in for a 90-minute eval with the neurologist. You're gonna see a nurse practitioner, a social worker, myself, any type of therapist you need to see, someone to schedule your infusions, the medical assistant, all that stuff. So you're getting a one-stop shop to triage your needs. Now, the way we do it is a little bit different. All of the neurologists I work with are neuroimmunologists, so it's not just a general neurologist. We see our clients at least every 3 months. So we're really getting the opportunity to see how they're progressing, and it's not just, follow up in a year, follow up in a year. They're coming every 6 months to a year for a new MRI, so we have the opportunity to see how they're doing. And we're really able to address the needs before they become detrimental to them. So my job as the physical therapist in the clinic is to refer to all of the therapy services that they need. I didn't write physical therapy on there, which is kind of strange, because typically they always need me. Pelvic floor therapy, I think, is critical in the MS client, and it's going to affect your seating as well. These clients that you're going to talk about a manual wheelchair for, do they have enough endurance to get to the bathroom? So it's critical. I would say, I don't have the exact numbers, but I would say at least 80% of the clients that I see in MS clinic have some sort of incontinence issue. Obviously, we're referring to the wheelchair seating clinic, and then often we're going to outpatient neuro rehab to try and kind of tune up before clinic so we can really see what they're able to do. So this diagram looks at the progression of MS. So if you're chart reviewing your client before they come to clinic, they should have something called an EDSS. So that is basically a numeric rating of their disease progression. And then I'm going to pull up some kind of words. I hope you guys can see that from there. So when you're looking at how they're categorized on their disability scale, all of these talk about their ambulatory status. So at about 6.0, they're starting to only be able to walk 100 meters. They might need a unilateral device. At about 5.0, 200 meters, and so it goes down. But when you're talking about funding for a chair, it's not, can they safely walk? Can they get to where they need to go? So some of the drugs that they're on, they might need to come to the hospital every 28 days to get an infusion. Every 3 months, they're coming to see their neurologist. And I was pulling up some numbers. When you're looking at walking in a hospital, average distance is 100 to 200 meters to be able to walk into the hospital, get their infusion. Their infusion is extremely fatiguing. They're there for sometimes 8 hours to get this infusion, and then they need to leave. So this is part of their day-to-day life. It's not about, the short distances, because their short distances are typically fine when we're talking about the beginner chair. So this is going to tell you a lot about, what you're necessarily thinking. So just briefly, the different drugs that they can go on. I think what's really critical for us as providers to understand is how much this is changing. The first disease-modifying therapy drug for MS came out in 1993. There's 14 drugs total, and since 2006, there have been 9 new drugs. So the goal of all of these drugs is no evidence of disease activity on an MRI. But that doesn't mean you're not going to have the situation where they're getting worse and they're catching up to their MRI. And it means that we're really trying to maintain their physical functioning. So yes, they might have a hemipresis, but they may look like that for a long time. If they're on some of these infusion drugs, typically they have a highly active and aggressive disease. And like we were talking about earlier, access is crucial. They need these drugs. So if they're going to be going to the hospital every 2 weeks, and it's a fatiguing drug, are you really going to look at manual? Because they're not going to be able to be independent, likely. So just understanding that. Typically, they're all trying to run through the list of different devices and bracing before they even want to have the conversation about wheelchairs with us. The nice thing about me being in the clinic is I can kind of paint a picture of what it will look like, what to expect, how your appointment's going to go, and just because we're talking about a wheelchair doesn't mean I'm talking about a power wheelchair with you, or kind of vice versa. So, everyone knows what these are. So I'm going to turn it over to Carina briefly.
All right. So I'm going to talk a little bit about our wheelchair clinic and some of the struggles that we had with trying to really transition. Our wheelchair clinic, I would say at least about 30 to 40% of our seating clinic is MS at this time. And that was not how it was several years ago. So I've worked in our seating clinic for 7 years now. When I first started, that's not what we were seeing. We were not seeing that many MS clients in our seating clinic. Then what happened was we hired these 2 neurologists that started this MS program that Lauren works for, and we saw our populations explode. And if you're a standard seating therapist, you don't necessarily always know. I'm a pelvic floor therapist. I know a lot about incontinence, but I don't necessarily know about all of these disease-modifying drugs. And especially, Lauren brought up a really good point of them catching up to their MRI. A lot of our clients were coming into seating clinic not really understanding why, when they had just had their MRI and everything looked the same, all of a sudden, a year ago they were able to walk and they maybe only needed to use a straight cane, and now we're talking about a power wheelchair. So that was very difficult to really explain to clients that were coming into our seating clinic, and it was hard as therapists because we're only seeing them for maybe 1, 2, 3 appointments depending on what we're recommending, and we're not really understanding why this is happening, or we're not understanding exactly what an infusion entails and why it wipes them out for 2 weeks, and then just as they're getting better, they have to go back for another infusion. So it really we had to do a lot of research on our part as seating clinic therapists, and that's why it was invaluable to have Lauren in the clinic, because we all see the MS clients, but she was able to explain and say, yeah, we just saw this person for their 3-month checkup, and this is what we're thinking, and this is why we referred them urgently into clinic. So it really changed the face of our seating clinic, having such a kind of high-level program for the MS clients and looking at what they needed from a mobility standpoint. So just to tell you about a little bit, our wheelchair clinic is fairly standard. There's either a PT or an OT doing our evaluation. We have our supplier there with us. And then we also have a physical medicine physician, which is great for us, especially for Medicare, because the chart notes are completed right there. And our physical medicine physician is phenomenal. We told him he's never, ever allowed to leave because he really has done a lot of research about what he needs in those chart notes, keeps up with the insurances quite a bit as far as what we need to write so that we are not getting denials because of his chart notes. And he sees the patients with us. So essentially the way it kind of works is that the PT or the OT goes in with the client first. We actually go through all of our PT and OT assessment. We call the supplier in and we talk to them about what we're thinking, and then we actually, as the PT, OT, and supplier, go and talk to our physical medicine physician before he even gets in the room. We kind of almost do rounds, so we present the case, we present what we're thinking, so he has a much clearer picture when he walks into the room of exactly what he's looking at and what he's going to need from a chart note perspective. The other thing that I didn't put up here, though, is our extensive intake process. And when I took over from a coordinator perspective, that was my big thing with especially these MS clients, was that we needed to do a better intake process. As Lauren said, MS is not MS. It's a different clinical picture. So what was happening was that we were, before getting these clients referred in, we would kind of automatically schedule them if they had MS, and here they come strolling on into the clinic. They were referred really, really early. They really don't need an assistive device. They have no idea why they're there, and they're really not ready to talk about a wheelchair. They're not even walking with an assistive device yet. So we really were like, okay, we've got to figure out a better intake process so that we can kind of discuss this with the clients before they come in and schedule them appropriately. And that was also partially before Lauren was in the MS clinic to say, yeah, they're not quite ready for an assistive device yet. Like, maybe we should hold off on that. They're still running. We had one person that was like running half marathons once a month, and I'm like, yeah, I don't think we can qualify you quite yet for a wheelchair. So we really had to streamline that intake process, and that's what I encourage with a lot of people, is to make sure that if you're going to be dealing with a population like this that is so variable, I mean, and all of our neuro populations are variable, but this one especially, clients can change presentation from month to month. So we actually, our intake process, I have a file of like, needs scheduled tomorrow. I have a file of can wait a couple of months, and then I have a file of we need to call them back in 6 months and see where they're at from a disease process. And then we have Epic, so we can chart review. All of our neurologists' notes are in there, so I can actually go in and look at their MRIs. I can see if there's new disease, or if, like Lauren said, they're just catching up to their MRI. So with this population, that is very, very critical. You can't just kind of treat them like some of our other seating clients. So the typical profile of an MS patient referred to wheelchair clinic, for I would say probably about 75% of our MS clients, this is their first assistive device. So they know nothing. They really have been kind of told some things by Lauren. If they saw Lauren that day, we have a couple of other therapists that they may get in MS clinic. So they may just, they usually don't know what they're walking into. Or they've done ridiculous amounts of research online. They come in knowing what chair they want, and we get to tell them, yeah, you don't quite qualify for that chair yet. Or your insurance company is not gonna pay for that chair. So it's an interesting dichotomy when we're looking at these clients coming in the door. Usually, most patients that are coming to see us are several years into their diagnosis. And as Lauren said, the age range on that varies. I actually just recently saw a patient in pelvic floor clinic with MS that was 14 years old. And they are seeing more really young teenagers being diagnosed with MS. And so when we're looking at their disease progression, we need to know, when were you diagnosed? How long ago? What disease modifying therapies have you tried? When did you first start seeing a mobility deficit? A lot of the younger MS clients, their first sign of MS is bowel and bladder changes. So they don't see mobility changes right away. And this is really kind of devastating for them because they may have lived, for 3, 4, 5 years with just kind of like, oh, I have to run to the bathroom every so often, and that's the only kind of really sign that I've had of MS, and now all of a sudden I'm talking about a wheelchair. So it's different from an acceptance kind of stage too, because they many times have had this disease for several years and kind of have accepted that they have a disease, but now all of a sudden they're having this progression and it's a different level of acceptance. So it's a lot, from a biopsychosocial standpoint, it's an interesting mix in clinic. Usually they've been on multiple disease-modifying therapies. A lot of times they're coming in and they've been on several, and now all those disease-modifying therapies are failing. And so they're scared because they don't know what's to come, or they don't know, am I going to move into that primary progressive where it's just, I continue that steady decline. So we generally have to do a lot of talking about that. They may or may not be ambulatory. As Lauren said, motor fatigue is the primary issue with MS. So it depends on what time we see them in clinic. If they're scheduled for the 9:30 slot, they may be doing okay, but they're telling us that, by after lunch, they're on the couch and they can't move. So that motor fatigue is really interesting, and so you can't really judge a book by its cover when they come strolling into clinic, because they may just be having a good day, or they're right at their time of the morning when they're actually feeling good. And they may or may not have an assistive device. So we see a variety. We see everybody from coming in, walking unassisted, or maybe they just have an AFO, all the way to, they are completely non-ambulatory. They have, had a severe relapse, and they went from being ambulatory to needing power, and they're not able to get around at all. So the clinical picture and what you're gonna see coming into the clinic is very, very different. We basically have learned we just have to chart review the heck out of these patients. We cannot just take it at face value when we see MS as the diagnosis at the top of their intake form. Common patient desire for first wheelchair. Almost all of our clients, regardless of their mobility, come in and say they want a manual chair or they want a scooter. Those are the two things that they say that they want. Because they're still, it's going back to that acceptance level. They have had MS usually for several years and were getting around fine. So that jump from I was walking about 6 months ago and now I need a power chair, when nothing really quote unquote happened. There's no accident like we may see with a spinal cord injury or a congenital issue. It's this slow progressive decline, and it's not as quick as it is in, say, our ALS clients, where we see a much faster decline. This is slower. They have a flare, and all of a sudden they have to completely kind of change their view on how their mobility is going to go. They're very resistant to power. And that's one of the things where we have to really look at their neurology notes, talk to Lauren, talk to our neurologists, and see, have we seen on this last MRI a huge flare and a huge evidence of new disease? So really, should we be looking at power, or could we maybe get away with manual for a couple of years? It's very, very difficult, and as Lauren said, it's kind of like a crystal ball. We really are trying to pull all these different things from the chart and from the neurologist in an effort to predict, because we don't have the luxury of saying, okay, we're going to get you a manual and a power chair. We really kind of have to decide, what are you going to have? And we definitely, if somebody has a major flare, that is a change in medical status. A lot of times we can maybe move them to that power chair. But with some of our commercial insurances, it's very difficult. For instance, even our insurance at Ohio Health has a max DME for the year, or it's actually for 2 years. And so if that patient needs a new chair in those 2 years, they're going to be paying out of pocket. And that's our insurance as healthcare providers. So it's very difficult to kind of really predict what they're going to need. And so sometimes we're talking to patients about, we're trying to talk to them into a more complicated mobility device, saying, well, you're going to get worse. And that's not the most fun conversation as a therapist to have. Like, okay, well, we think that in a year you're not going to be walking, so you need to get this chair. And that, so we get a lot of not so happy clients. It's not the easiest conversation to have. Home modifications are not a top priority. We have a lot of people that live in split levels that they're telling me, I don't care. I want to live in this house. I've lived in this house for 30 years. I don't want to move. I don't want to change where my bedroom is. I don't want to touch my bathroom. I had a gentleman in clinic just last Friday that refuses to modify his bathroom, and he can't get into it now. So he's like, well, my daughters just come over and do bed baths. It's fine. He's like, I don't want to move and I don't want to change my bathroom, even though he hasn't been able to get into it for the last 6 months. This is the kind of biopsychosocial stuff that we're dealing with. It's just not something that they want to think about, and home modifications are acceptance of that this is where I'm at and I'm not going to get better. With the relapsing remitting, what's difficult is that they do get better. So they are in that kind of mindset of, well, I'm going to get better. I'm going to get over this. This is not permanent disability. This is not permanent ambulatory dysfunction. This is going to get better. But unfortunately, they're in that place where they're not going to get better. So it's a lot of discussion. And then transportation of the power wheelchair is the largest barrier. And I think you see this with any population. Nobody wants to buy a van. Nobody wants to, they want a scooter because they can break it down. They can throw it in the back of their trunk. We do have great public transportation, and we have a great public transportation program in Columbus for our clients with disabilities. But again, if they've been driving all their life, and we see some people that they come into clinic and they're like, yeah, I'm still driving, and I'm like, oh my God, please, where do you live? Because I don't want to drive on the freeway behind you. So it's very kind of difficult even talking then about that transportation. I had a gal that we're going to talk about that wanted a scooter but literally couldn't transfer from the car at all. She was a dependent lift from the car, but said, oh yeah, I'll be able to throw that scooter in the back of my trunk. So it's a lot of talking about those mobility issues. Again, they're often seeking that POV, and then they have that difficulty coping with the loss of mobility. I can't stress that enough. That's really difficult. So when we're looking for clinical decision-making with this client population, patient goals are probably the most important for us. What do you want to be able to do? With one of the case studies that I'm going to talk about first, he coached his son's Little League and games, and that was his main goal. That's all he cared about. He didn't care about being able to get around in the home. He didn't care about he wanted to be able to get on the ball field. So, that was the driving force. He was like, no, I want a power chair because that's what's going to get me on the ball field. So that was, and he really was kind of borderline. So we really have to kind of look at what the patient goals are with this, because they are dealing with this new onset of loss of mobility. So we really talk to them for a long time about what they want to get out of their mobility device. And so then much smaller drivers for us are the physical abilities and then the lifestyle environment. Again, many patients are coming in and they have not thought about home modifications, there are times when in seating clinic, we are the first ones to talk to them about home modifications and what they're gonna have to do to be able to transport this chair or to use it in the home. And that's where we have great suppliers who also do our home evals for us and kind of talk to them about ramps and thresholds and things like that. Unfortunately, one of the things we complain about in our clinic all the time, so we are housed in our neuroscience tower, which is where all of our neurologic care goes, and it's a beautiful, brand new building that is way too accessible. So there are no thresholds, all the doorways are super wide, all the door buttons hold the door for a really long time. So when we're even trying to do wheelchair training with these clients, we're like, okay, this is not at all real world. You will never encounter an area like this again, so we need to talk about what we're gonna do here. So we're gonna look at three main things with the MS clients. We're gonna look at physical abilities, environmental, and again, their goals. So from a physical ability standpoint, we're looking at strength. We, on most of our MS clients, because many of them are ambulatory, we really rely heavily on our balance tests. So we do, from a balance standpoint, we do a Tenetti or we do a Berg on all of these clients, because they may look great walking into the clinic, but they also sometimes have been dealing with these mobility issues for a while, so they've really learned to compensate. They may look great from afar, but if you do a functional balance test on them, they don't look so great anymore because they can't now compensate for those balance deficits.
And even to that point, they may look great walking straight. Ask them to walk and turn their head. So depending on where their lesions are, if they have a lesion in their cerebellum or a lesion in their brainstem, they're gonna fall over. Mm-hmm. And that's real life. I'm walking in the grocery store and I need to find the cereal that I want. Well, that just changed everything. Yeah. Because they are really good at compensating. Mm-hmm. You have to make up for what you don't have. And so you need to look dynamically at their balance, not, let me stand here with my feet together and close my eyes. Well, who does that? I don't know, I only close my eyes when I'm washing my hair and I need to rinse out the soap. You need to look dynamically at what they're gonna be able to do, because that's how you're gonna justify their chair.
Mm-hmm. Yeah, and that's, and like we said, that compensation is huge because these changes have happened slowly over time. So they have gotten really good at compensating for each of those changes because they've lived with them for as long as they have. So it really, sometimes it's hard to tease out some of those functional mobility deficits. And there are times when we're spending, almost our entire hour just doing functional tests on these clients, trying to figure out how we're gonna justify this chair. It's definitely sometimes a more complicated seating appointment than our patients that, our spinal cord injury patients or our ALS patients, because we've got that kind of crystal ball and we're trying to figure out what deficits they actually have. Fatigue is probably the biggest one. So again, we may see them, the reason why I brought up that our clinic was too accessible is because it's flat and there are no thresholds. They're just wheeling around in a manual chair, great, because there's nothing stopping them. It's flat, there's no actual obstacles. It's really a nice circle. And there's nothing that would challenge them. So they're like, oh yeah, I can do this all day, until we take them outside where it's warm, because the heat can bother them from an MS standpoint, and all of a sudden, now they can't get out the sidewalk to the parking lot. So we really have to look from a fatigue standpoint, or again, I mentioned earlier, if they're the 9:30 clinic appointment, which we try not to do, we try to have our MS clients towards the end of the day, but if they work or that's the only time that they can come in, they may come in feeling great, and then when I ask them, well, what about today when you go home? Well, I have to go home and I have to lay on the couch for at least 3 to 4 hours before I can get up and make dinner. So we have to kind of take that into account from a fatigue standpoint. Posture, there's a lot of compensations that they tend to make. Spasticity, varying levels of spasticity, and our spasticity clinic is housed in the same area, and they may be looking at a baclofen pump. So then we also have to take that into account, that they're maybe now using their spasticity to walk and stand and transfer, but they're getting a baclofen pump in 2 weeks, and now they're gonna lose all that spasticity, and they're gonna be, really loosey-goosey, and they're not gonna be able to transfer the same. So there are times when we have to look ahead from that standpoint and say, all right, we're going to do a functional assessment now, but we're going to do another functional assessment in 2 weeks after you get that baclofen pump and see where you're at. And that's where sometimes we've even convinced people that have said, no, I want that manual chair, I'm going to be okay. And then they get that baclofen pump and they can't propel 5 feet. So taking into account that spasticity and what they're going to be doing for that spasticity is very important. Pain and range of motion limitations, things that we look at with every seating client, prior orthopedic history, cardiopulmonary. Sensation, I have one MS client right now that I'm treating from a pelvic floor standpoint that is basically numb from the waist down. She is ambulatory, but you can throw something at her and it'll bounce off her leg and she'll have no idea. Just completely numb, which is a huge thing when we're talking about seating, obviously, because they just do not have the same sensation because of where her lesion is and what her MRI looks like. That's her main deficit, is that sensation. And then incontinence is a huge one. So obviously as a pelvic floor therapist, I'm gonna be most concerned about their incontinence. And I'm gonna be asking them if they're doing their Kegel exercises all day. But even from, we had one patient that her incontinence was completely functional incontinence. She just couldn't make it to the bathroom on time. You add that to a neurogenic bladder that's contracting uncontrollably, and she was incontinent all the time. As soon as we got her an assistive device, her incontinence went away because she was able to functionally make it to the bathroom. So we have to take that into account as well. From an environmental standpoint, we talk about home access and home setup, work. Most of our clients are still working. The people that we're going to talk about in our case studies are very high level working, and they really have a lot of job barriers that we had to talk about when it came to their assistive device. Distance traveled. I just had a client, so Columbus Nationwide Children's is our big children's hospital, and all of the employees at Nationwide Children's have to park about 6 blocks away from the hospital. And we have a lot of clients that are in our seating clinic that work there, and so they have to figure out how they're going to get 6 blocks in time to get to work. So they don't want to get to work an hour and a half early so that they can walk those 6 blocks to the building. And general transportation, what are they thinking about from a vehicle standpoint? Are they going to be using the public bus system? Patient goals are usually maintain independence is always the #1 goal. Aesthetics is huge for our clients. They want to make sure that they're not going to look disabled because they, a week ago their coworkers saw them walking and now all of a sudden they're going to be in the chair. So it's really, we have a lot of clients that are very, very concerned with that. And sometimes that's one of the reasons why they want more of a scooter, because to them it doesn't look as, they don't look as disabled as if we got them a power chair or if we've got them a manual chair. Home access and work access, and then family participation. Really, making sure that they're still able to participate in all of their family activities, because again, a lot of our clients have young children, and they want to still maintain activity with that. Some of the things that we look at from a therapist standpoint: time of day of evaluation, how close to their last infusion or disease-modifying therapy, because they're going to look different if they're closer to that infusion than if they're, a little bit farther away from it. So we really do a heavy chart review with those clients to think about that. Have they had a previous mobility device, and are they currently in PT and OT? The great thing about our MS program is that they do a lot of kind of bouts of physical therapy where they may come in for 2 to 4 visits to update an exercise program or to help with some of their balance deficits. And so where are they in that program? Are they getting better, or am I reading the therapist's notes and they're about to discharge them because they feel like they've reached their maximum impact? So it's a little bit different because they're constantly in and out of therapy, which is different than some of our other neurodiagnoses. Current insurance versus insurance changes. So, yes.
So the most typical one, a drug called Tysabri, you get infused every 28 days. And I have clients that will tell me the week before my infusion, I'm always wondering why I don't feel good. And then I get it, and I call it superhero juice. They feel fine. They feel wonderful. They still have their balance deficits, things like that, but kind of the week leading up, like my leg's been dragging, I'm really tired, like I'm resting more, I feel clumsy. It just depends on the patient, but they really start to notice, I don't feel very good. And unfortunately, kind of sometimes the reason we talk about failing a disease-modifying therapy is now that time's gotten longer. Now it's 2 weeks. So every 28 days I go, but for 2 weeks I feel like crap. Like, is that really working? So, the big drug, and if you start looking at these things, the drugs you're gonna really look for are Limtrada, and a new one that's coming out, it's called ocrelizumab. If they are on those, they have very aggressive disease. They have failed all other options. And these drugs are chemo drugs. Like, these are knocking you out. They come 5 days a week, and they sit in a chair for 8 hours, and they get infused on when they're doing a Limtrada. Now, they don't get infused again for another year, but you're talking about someone who everything has failed, and this is their shot. It has really good data that it's keeping relapses at bay, 60% reduction in relapses on Limtrada so far. But if they're on that, they're gonna have built up a lot of lesions on their brain or spinal cord. Yeah. Yep. Yeah, to a certain extent. So what the drug is trying to do is to not have any more activity. So there's a lot of other drugs that we could really talk for hours and hours about, like something called Ampyra. So what that does is it tries to speed up the nerve conduction velocity. So what MS is basically a destruction of the myelin sheath of the nerve. So they're trying to increase the action potential so it can still connect. So if you see someone on their Ampyra and off their Ampyra, you're like, what just happened? Now, not everyone can take Ampyra, but those are things that if someone's on Ampyra, it's likely a lot of motor fatigue that is their barrier. But really asking that question, when you're trying to get to the hospital before your infusion, what do you feel like? Oh, someone always has to grab the loaner chair at the hospital and take me. Well, you should be independent. If we have that ability and you want to be independent, nobody wants someone to push them. So, thinking about what are these things that they have to do. That's over 12 times a year that they're going to the hospital to get these infusions.
And Lauren brought up a good point. I mean, they're chemo drugs, which was surprising to me when I first started really dealing with this population. So you're dealing with things like immunity. So we've had people cancel their wheelchair clinic appointment because they're about to go in for their infusion and everybody is sick. It's winter in Ohio and they don't want to get sick before their infusion because it will delay their infusion. So it's a lot of different things that you're dealing with, and if you don't have somebody that you can use as a resource, like we thank God every day that Lauren is in clinic because we can say, what is this drug? What does this mean, and why are they telling us this? Because you don't have time to know every single drug out there on the market. So therapist considerations, current insurance versus insurance changes. A lot of patients, depending on where they're at, if they are all of a sudden now maybe applying for long-term disability, or they're moving from commercial insurance to Medicare because they're going to be reducing their work hours, or they're going on Medicaid. So we've gotten burned on more than one occasion where a patient has come in and they've told us they have commercial insurance, and they're literally walking out, the clinic door, and they're like, oh yeah, by the way, next month I'm going to have Medicare. And we're like, all right, come over here, come back. So really, we try to talk to them about that in clinic and say, where are you at? Are you going to have this insurance for a while? Desire to continue working, so we ask them, where are they at in that plan? Are they looking at retirement? Are they looking at long-term disability? Or is that not even in their plan right now? What are those mobility-related activities of daily living and their living situation? Are they going to change that? We have had a couple of people that have come in and said, I realize I'm not able to get around in my split-level home anymore. I'm selling it, but I don't know when I'm going to be moving. So, we're kind of talking about what are you looking for in your home situation? And then transfer safety. I would say, and this is just my kind of observation as a therapist, some of my clients with MS, they're doing the scariest transfers I've ever seen. Because they're used to being mobile, and so the things that they're doing to get from their chair to a toilet seat is like, it's horrifying as a physical therapist. And then they yell at me when I'm trying to do standby assist, get away from me, I don't want your help. And so it's very, it's really, we want to look at those transfers. So a lot of times what I do is when we're about to trial a chair, I don't help them at all. I stand across the room and say, show me how you would get into that chair, because it gives me a good idea of what they're doing at home rather than what I'm going to do as my nice, safe therapist sliding board transfer. And, you know, I mean, I had one client that was like, don't even, he told me as I walked in the room, don't pull out a sliding board. I don't want to look at that thing. I've had 3 therapists tell me I need one. I'm not using one. So it's looking at that, and it gives you a lot of consideration from a prescription. Some of the insurance barriers that we've seen, patients are still ambulatory at the time of their evaluation. They're coming in, and like Lauren said, if you looked at them across the room, you'd go, they don't need a wheelchair. They don't need any sort of assistive device. They look fine. But you ask them to turn their head, and they literally almost fall over. Or you ask them to walk around the hospital. You know, we'll even just go down the way to the Starbucks in the hospital, and now they have to sit down. Because they're masking a lot of things. So we almost try to wear them out, and sometimes when I'm on the phone with them doing intake, I will say, we may try to wear you out that day. We may have you walk around the hospital a couple of times and then come back to seating clinic so that we can see what you look like with some motor fatigue. And then that helps us from an insurance standpoint. High insurance deductibles, if they're on commercial insurance, we're seeing it more and more, even from a therapy standpoint. You know, people coming in and they have a $7,500 insurance deductible. They haven't had their disease-modifying therapy that year, or that year quite yet. They don't even want to pay the $365 for my PT eval, much less for a, you know, $10,000 wheelchair. So talking to them about their insurance deductible and what they're going to have to pay. And then just resistance to assistive devices altogether. We get a lot of people that have come into clinic and they think that they're ready, and we start talking to them and we start showing them things, and they're like, I'm not ready for this. And so we've had to say, okay, that's fine. We will call you in 3 months and we'll have you come back. And generally they're calling us before that 3 months is up and saying, you were right, I need something. But they kind of have to come to that realization on their own. We can't really force them into that. Again, too mobile, even just from a transfer standpoint. Current bracing and assistive devices may make the patient too functional. So they've had a lot of assistive devices, or they've had a lot of braces. They don't have the strength to stand on their own, but because they've got a KAFO, or they've got an AFO and a knee brace, and they're, you know, braced to the hilts, they're like, I'm fine, I don't need this. So it may make them a little too functional, but if we take all of that off of them, now they can't get around. And then they may live alone and may not be safe transferring in and out of the device. So we've seen that on occasion as well. The disease-modifying therapies are expensive. How much is?
You don't want to know.
It's, you know,
it's more than a house sometimes.
Yeah, I mean, the cost of some of these drugs that they're on is very high, and luckily at MS Clinic, they have some fabulous social workers, because a lot of times even the cost of the drug, they may get delayed 2 or 3 months getting their medication because their insurance doesn't want to cover it, and the patient doesn't have $100,000 to spend on one dose of a medication. So then we're coming in and we're like, oh yes, and you, by the way, need a $20,000 power chair. They're like, yeah, see you later. So very difficult to kind of talk about that sometimes. Other equipment needs, so, you know, we have to talk about not just wheelchairs. We will talk to them about, you know, bathroom modifications, toilet chairs, hospital beds, all that kind of stuff. But it's really difficult. And then recent equipment purchases. So we had a really hard time with our inpatient rehab unit and some of our home health therapists giving people basically transport chairs. And having their insurance company pay for it. And then the patient comes in and we're like, yeah, we ran your insurance. The patient thinks that they rented that chair or it was given to them by the hospital, which is always my favorite. I'm like, you get nothing from the hospital for free. Like, did you really think you were gonna get this wheelchair for free? But I had a patient that argued with me, like, no, the hospital just gave it to me. Sure they did. So, you know, we have to really look at that, and we have been stuck before where, you know, they were in a rental, they did not realize, nobody explained to them the capped rental process, this chair is now theirs, and we can't do anything for them because we really can't show any change in medical status. They got that chair when they left inpatient rehab,
After just having a relapse.
And they haven't gotten any worse, but that chair was never appropriate for them for the start. So we had to do a lot of education with our home health therapists and our inpatient rehab therapists about that. Okay, so we're going to talk a little bit about case studies. These are all patients that Lauren and I saw in clinic, and they all had very, very different presentations. So my first patient, he was a 43-year-old man at the time of evaluation. He was still working as a construction site supervisor. So uneven surfaces galore. He was responsible for any Lowe's that was built in the state of Ohio. He would go out and supervise the building of these Lowe's. And so he needed to be able to get around. He was one of those ones that walking into the clinic, you would go, you look really functional, why are you here? But as soon as we asked him to do anything from a balance perspective, he had no balance whatsoever. He couldn't turn his head, he couldn't walk quickly, he just had really compensated. He had 2 young kids, and he was ambulatory on his good days, non-ambulatory on his bad days. So he would tell us that, you know, even though he looked good today, if he was in the middle of a relapse, he had trouble getting out of bed. And he was also 6'9", and weighed about 300 pounds, and his wife was like shorter than I was, and there's this tiny little slip of a thing, and so she couldn't help him move around when he needed to get around on his bad days. He was Medical Mutual of Ohio for insurance, so he was a private insurance, and his goal was to be able to coach his son's baseball team. He really, his son played Little League, that was their bonding experience, and he told me, he goes, I don't care if I trip and fall on the construction site, but I don't want my son to see me trip and fall on the ball field. I want to be able, even on my worst day, to be able to get out to the ball field and still coach my son. And so he was the one that wanted power, but was very, very skeptical as to if insurance would pay for it. He had gotten burned several times before on some of his disease-modifying therapies and his insurance denying him, and they couldn't get things approved, or it took a very long time. So he came in with the expectation. He told me, he sat down and he was like, this is going to get denied. This is what I want, but it's going to get denied. I mean, he was very adamant about that. So on his eval, he had really poor balance overall despite being ambulatory. He had a Berg of about 28. He was not appropriately using his assistive devices, so he carried his cane around. It was doing a lot of good with him not actually ever putting it on the ground. His lower extremity strength was much worse than his upper extremity strength. He was very easily fatigued. So initially we did try out a power or a manual chair with him. I tried out a Smart Drive. He really just didn't like it, and he didn't feel like it was going to give him enough power to get around on the ball field. And because he was so large compared to his wife, he just said, I really don't ever want my wife to have to push me, even if I get too fatigued to use the manual. So he was really kind of very adamant about wanting a power chair, even though he was convinced he was never going to get it paid for. So what I recommend was an Amy Systems mid-wheel drive with power tilt, power lifting leg rest, because he had a lot of swelling, and on his bad days, he had a lot of spasticity, so we wanted to use it for spasticity control. Standard seating, he had good skin. He was able to weight shift sometimes enough, and with the tilt, I really wasn't concerned from a pressure ulcer standpoint, and he was really good about looking at his skin and making sure that he was good there. So he was right. He was initially completely rejected by his insurance company. So we got the denial letter, and he called me up, and he was like, see, I told you so. And I said, well, I'm not going to take no for an answer. So we had him come back in, and I actually had him come in on a really bad day. So luckily, you know, he kind of was having a bad week, and he said, you know what, I think I might be able to come in this week. I had him come in that Friday, and we kind of redid some of the tests, and he did worse, which was not surprising. And then I also had a really, really good chart note from my physical medicine physician about his spasticity and how much that was really affecting his mobility. And the second time we submitted, it was approved by the insurance company. So he got his power wheelchair. Now, it's funny all the time because I see him in clinic and he's not using it. He uses it on the ball field. But he said, he did tell me the last time I saw him in clinic just last Friday, he said, I'm having to use it at work a lot more. So I'm really glad, because it's only been about 6 months that he's had it. He said, I'm really glad that we didn't wait, and I'm really glad that we pushed for this to get approved, because he goes, I would have been hurting on the job site now if we hadn't pushed to get it approved. So just one of those cases where, you know, he was private insurance, and he really, even though he was ambulatory, he needed that power chair because his presentation was so variable from day to day. If you saw the scores between the first time I evaluated him and the second time I evaluated him, it doesn't, if you just read it, it doesn't look like the same person based on the therapy eval. So the second one I want to talk about was a completely different presentation. So she was a 57-year-old female. She's a lawyer. She's actually works for the Attorney General for the state of Ohio. Very high-powered lawyer, very like the rest of us PTs, like type A personality, very, very anal retentive, comes in and like dominated most of the eval with just talking to me and telling me what I needed to do. And she was very, very concerned about work. So where she, because she works for the Attorney General, she needs to get downtown. Parking in downtown Columbus is not great. There is nowhere by the courthouse that you can park that's really close. And so she wasn't able, she was literally calling people from her car, and this is what she does from therapy. She calls you from her car and says, somebody come get me. It's time. And don't be late, because then she'll yell at you. So she needed something for work. Her home eval was not great, though. She actually lived in the same town that I lived in, and she told me where she lived, and I said, those are probably the least accessible townhouses in the state of Ohio. Like narrow doorways, everything is steep stairs. I said, where do you think you're gonna put this chair? And she's like, I'm gonna leave it at work. It's gonna be fine. But she had such a rapid decline in function, I didn't know how she was even getting around her townhouse, because she couldn't stand, she couldn't even really sit. We had her sitting edge of mat for 5 minutes, and she all of a sudden decided she needed to lay down because she was that fatigued. The problem was very much biopsychosocial with her. This is a woman who is very powerful in the state of Ohio, really has a lot of powerful people around her, and went from being able to run all over the place to not being able to sit edge of mat for 5 minutes in a very, very short span of time. So she was not accepting this decline in function. She was still working with NeuroClinic a lot because she was trying to find a reason for why she was having this rapid decline in function. She had really poor core stability, horrible lower extremity function, spasticity, and then she also had a lot of left versus right weakness. So she was an interesting presentation in that her legs were weak, but then she also had a lot of left upper extremity weakness. So again, she lived in a townhouse with stairs, really steep stairs, everything was very narrow. She was not wanting to purchase a new vehicle. She drives a Lexus, doesn't she? She drives a Lexus SUV, and she's like, I love that car, it's my baby, don't tell me I'm gonna have to buy anything new. From an outcome standpoint, what I recommended initially was a Permobil F3 tilt recline, and I didn't put it on there, power elevating leg rests. We just did standard corpus back and seat because, again, she shifted a lot. Even though she was weak, she is one of those people, like, she wanted a wider seat because she likes to tuck her legs up underneath her and sit kind of sideways half the time and move around a lot. So we weren't really worried as much with pressure. Tilt and recline was more for spasticity management and relaxation, so that she could continue working and work an 8 to 10 hour day without having to lie down on her couch in her office. So we were able to get, from an insurance standpoint, she got approved fairly quickly, so it wasn't a problem with insurance with her. But when I did her follow-up, she came to the clinic to see me for bowel and bladder stuff, and I got a phone call, you need to come outside and get me. And I said, okay. I go out there, I said, where's your wheelchair? Oh, I told you, I leave it at work. She's using a scooter most of the time. She went and bought just a plain jazzy scooter, but she's really dangerous in it because she can't transfer in and out of it at all. When I got her out of the car, she was almost a max transfer. Luckily, she's a tiny little thing, so I kind of lifted her out of the car into the chair. But just there's no telling her that she needs to use her power chair more. And she uses the scooter to get back and forth from her car. So she leaves the chair at work a lot of times and then takes the scooter out to her car. And she just has horrible transfers. So like I said, she's one of those ones that scares the heck out of me when I see her trying to self-transfer. So it was one of those where it's very actually frustrating, because here we got this really nice power chair for her, and she sees the need for it, but she's still not using it. So we're going to move on to some of Lauren's cases.
So in case you didn't notice a theme, got you a wonderful chair and you don't use it. But I always tell people, you have it when you need it. What I've noticed is they slowly start using it more, and they slowly realize how this does help from an energy conservation standpoint. Question, yeah?
Yes, I'm an OT in the AT team. I work with the MS team at my facility.
Mm-hmm.
And some of my MS clients who are really perseverative about having a scooter, when they need a power chair, I have been successful and a few times put a joy bar, the scooter-style tiller that mounts on
Mm-hmm.
the power chair
Mm-hmm.
on a few cases.
Okay.
Sometimes, usually they'll lean off of it because they really need the joystick
Right.
for them to accept the power chair.
Mm-hmm.
That works out.
Yeah.
So for those of you that are in the back, she was talking about putting kind of a joy bar that's a tiller style on a power wheelchair to help with some of that acceptance and some of those optics, because that is a big thing, is optics with those patients.
So this next patient is probably one of my favorite patients of all time. I still get like emails in the medical record like, it's your favorite pain in the ass. I'm like, I never called you that. Please don't put that in the chart. But that's neither here nor there. He's a 53-year-old male. He's got primary progressive MS. He's so active. I have never seen someone who worked harder. He was exercising daily, doing all of the household chores on his knees, working outside in the garage, doing yard work, all that kind of stuff. And you read that, you hear that, and you're like, well, you know, that's awesome. So he walks, but he walks with his arms. So he had a roll light walker, which is probably my favorite, where he would just push up, tiptoes on the ground, swing his body forward, keep going. So his upper body was strong. He could not lift his legs against gravity. He's the type of person who is just adamant about he's gonna walk, he's gonna walk, he's gonna walk. He used all of his tone to stabilize on his tiptoes when he was using that walker. He had a baclofen pump, and I would always tell him, like, you need to go down, we need to go up. His spasticity was ever changing. He really wanted a manual wheelchair. There was no way we were gonna talk about power. And he needed it for community access. Him and his wife loved to go to the casino, favorite thing ever. And then he wanted to use it in the evening hours because he would get so fatigued. He would get so fatigued to the point that he would leave the house using his walker. He would crawl in his home at the end of the night. Crawl, and that was okay. That was what he did, and I'm like, what? Like, what is going on right now? Didn't matter, he didn't want to talk about it, so we went through an extensive bout of rehab. He would see me in the clinic. He would drive 90 minutes to come see me just for treatment, so I'd only see him like once every 3 weeks and give him a whole new program, really trying to progress him. And I would tell him, like, we're going for broke, we're gonna see what you get, but at the end of this, you're coming to see me at wheelchair clinic, because I knew what it was gonna look like. I knew he needed something, and that was our deal. So on eval at the wheelchair clinic, he told me he's falling 5 times a year. No way, so much more than that. His Tenetti score was an 11 out of 28, so less than 19 is high risk for falls. His right leg was grossly 3 out of 5, left leg 3 minus was generous. But significant motor fatigue. Yeah, he could do this one time because he would activate spasticity. Okay, do it again, do it again, do it again. We're going for 20, get to 5, nothing. So that's really how I want you to look at motor fatigue. Okay, 5 out of 5. Keep going, keep going, keep going, keep going, keep going, keep going. I can't do it. Okay, so you think you can do a manual wheelchair? Okay, so thinking about that, because they don't understand that. They don't understand how much force you have to generate. You have carpet in your house? Oh, okay, let's try that. And you have to show them because they don't understand. His posture was actually really good. He already had a ramp, already had the 1 story. He just would have one step to get in his house from the garage, but he could use the ramp on the other side. So we ended up doing ultra lightweight manual motion composites, Java back, and a forward cushion. It was fully funded. Call him 3 months later. How's your wheelchair? Oh, it's in the closet. Okay. But I'm going to the casino tonight, and it's coming out. Okay, I'll take it. Now, he has gotten, since then, he's gotten a little bit worse, and his wife tells me he keeps looking over at the chair. Like, he'll look at it. She's like, are you going to use it? I don't know. So he's warming up to the idea. But, I mean, he's someone that I really wanted to do a smart drive for him. No. I can push this chair on my own. So we got him the lightest of the light, and he's already said, like, okay, I'll come back and we'll talk about a smart drive. But this was someone, in a million years, no one at the MS clinic, none of the doctors thought we could even get him anything because he was just so adamant. But he did use it at the casino, and he loved it. The next client is one who always tugs at my heartstrings. 30 years old, working full-time as a nurse, so she did phone triage. She had just had a relapse. She had horrible spasticity. She has a baclofen pump. So Carina was talking about kind of baclofen pumps and using your spasticity to walk and all that kind of stuff. I'm a little bit fortunate that I get to see these clients through kind of every episode of their care. So their neurologist visit, their outpatient neuro rehab, their wheelchair seating, I do all of their baclofen pump trials. So they come in, they spend a whole day with me, and I assess them as the baclofen's working, as they're teetering off. So I really get a good idea of, when we knock out your tone, what do you look like? So I can have that conversation there. If I know they're going to get a baclofen pump trial, we usually don't do seating clinic beforehand. I want to know what they look like before I see them in the seating clinic. So I have a unique situation, but she has very, very aggressive MS. This is someone who caught up to her scan. A year ago, she was walking with a walker. Lot of spasticity issues. She's someone who, again, had a lot of incontinence, but she couldn't get to the bathroom, couldn't manage her pants, couldn't do all that stuff timely enough, so she would have an accident. And she's still at work, so she would have to ask some of her nursing colleagues to help her, and it was very degrading for her. Once we got the baclofen pump, spasticity was removed, and she was the most sensitive patient I've ever met in my entire life to baclofen. Average dose of baclofen, this is kind of outside of the scope, is like maybe 500, 600 micrograms. She was on like 10 and was like a spaghetti noodle. It was insane to me. So we have slowly been like increasing it, trying to build up core stability, all that kind of stuff, and it is not, she's got a rough go of it. And we were telling her, we need to get you in the clinic, we need to get you in the clinic, we need to get you in the clinic. Finally, she agreed. I was like, Carina, urgent eval, let's go. She was falling all the time. She had just, like the week before, gotten stuck between the toilet and the bathtub. She was living by herself. She would call her mom to come help her. I mean, it was a bad situation. So she gets there, and of course, she wants a manual chair. She could not propel a manual chair. We went with ultra lightweight, hooked up a smart drive. She couldn't even initiate a push. She couldn't even start the smart drive. And of course, I saw her on her worst day. So then she'd say, well, when I'm doing well, I'll be able to do this. I want to come back in when I'm feeling better. And I looked at her and I said, you need this at your most when you're having a bad day. Because when you're having a bad day and you have to go to work, are you just going to call off? Or do we get you something that you can use no matter how you're feeling? If you're feeling good and you can still walk a little bit, then you can still walk a little bit. But if you can't do this today at your worst, I can't recommend something that you can't propel in front of me. So then everyone was crying. It was a bad situation. So I said, we're not going to make a decision today. We're coming back for a follow-up. So by the time we were back for the follow-up, it's not really a secondary evaluation, just a follow-up appointment. She was ready to talk about power. She'd already decided, okay, I'm selling my house. I'm going to move in with my mom. The psychosocial stuff had really been figured out because I had told her, I need you to call the social worker at the MS clinic. So she has that person who she can talk to, and it's kind of, not that I have a vested interest in what type of chair she gets, but It's someone outside of that. Well, how is this really gonna look? What's life gonna look like? So she came in, she was ready. We tried Permobile F3, all power seating functions, practice in the clinic. She did wonderful, and at the end she was crying again because she was so happy. So she's now, she ended up buying basically like a transportable like power scooter that she's using in the meantime until she gets this, and then she can use when she travels. But this should be, I think, delivered next week, which will be wonderful for her. She's gonna keep this one at work, and they're gonna use the other one to get her to the car. Mom's gonna drive her to work, and then her chair will be waiting for her at work, because her job has been wonderful from that standpoint. She can just keep it there and charge it overnight. All right.
So just in conclusion, I think the thing that we, really wanted to hit home, and we hope you got from some of those case studies, is just how variable these patients are going to be when they're coming into seating clinic, and just how much you have to know from the medical side. You can't really look at them just kind of on that day and be blind to what's going on with both their disease-modifying therapies and kind of their general function. You really have to kind of take all of that into consideration when looking at this specific client population. So, any questions? Okay, I think we have, oh, yes.
Yeah.
In many patients, that's kind of before they even go to the neurologist, they will often note bowel and bladder issues first. And what I get a lot from a pelvic floor therapy standpoint is they come in and I talk to them about how they were before they got diagnosed, and they'll tell me, I had a bladder of steel. I could go 12 hours and never go to the bathroom, and then all of a sudden I was going to the bathroom every hour. And so they're sometimes referred to urology first, or it takes a little while, but for many patients, the early signs and symptoms are so mild that it sometimes can take them a while before they end up at the neurologist and being diagnosed.
You have a question in the back? Absolutely. Well, and to that point, when we're talking about resistance to home modifications, the National MS Society has funds. I mean, when you're talking about something like MS, you got a lot of pharmacy money, right? So while we don't wish anyone has that diagnosis, there are a lot of resources that you can tap into, so that you can tell them about the National MS Society, you can tell them about the MS Foundation. The MS Society alone gives people up to $750 a year to go towards medical expenses that their insurance doesn't cover. So you're talking about your ramp already helping with that. You're talking about some car modifications. And then there's all these grants that are called like the Light Break Grant, something that's gonna brighten your day that'll be like $2,000 to help with car modifications. If you let them know they're out there and hook them up with a social worker or just give them the resources themselves, we can get a lot of this funded. I've gotten someone's scooter funded so that they can just go to Disney World, or there's the loan closet where they'll loan you one so you can go to Disney World. And then you just bring it back when you don't need it. So there's so much out there that we can really make a big, big difference. Any other?
Right. Oh, yes.
Yeah. So I tell them, I say, tell me about your worst day. That's what I want to hear about. Tell me about your worst time of day, and how does it affect you? So your motor fatigue is bad. What can't you do? Oh, well, my motor fatigue is bad. I can't cook dinner for my children. I can't get out of bed. Someone has to help me. So I say, patient was, independent with transfers. However, they report that by 3 p.m. they are a max assist with transfers. You're not lying, but you can't see everything. And I'm telling you, if you ask them to do repeated motion, you're gonna see it. And that's one of my biggest issues why I almost never do a scooter, is most of my patients, I just say, okay, hold your arms out, keep holding. How long can they do it for? Because that might be their whole day. And then they start to realize, like, oh, that actually would be really hard for me. And you don't want to ever give them something that's going to add to their fatigue, because it's already difficult enough as it is. Any other questions?
All right, so we have your code. Oh,
Here, bring it up to us.
Thank you.